Excellent. Thank you very much. Terrific presentations. So now we have an opportunity for questions and comments, discussion. We have 2 microphones. I guess they're up the aisles, each aisle. And I'd like people to come to those microphones to ask their questions so that the comments can be captured for the broader audience that we have on the web. So if you'll make your way up there, I would just say a terrific start to this meeting. Thank you, panel, very much. So as we have our first comment, and you're interesting the positioning of the light there, so I can't actually see who's there. So
well, that's a good thing, man.
Please, ask
my name is Patrick McGarry. I'm a roundtable member. I'm with the American Academy of Family Physicians. I'd like to commend the presenters for a wonderful presentation. And Andrew, I think you did a fantastic job, and your colleagues with the paper. Previous to my current career, I served 17 years with the Illinois Department of Public Health, and I was not surprised to see a big blank there because I've been promoting health literacy for quite a long time there and to no avail. One of my concerns is the Public Health Accreditation Board has created standards and measures. There's currently an initiative underway to accredit public health agencies across the country, and they only have one measure, and that being documentation of the provision of information of health risks, health behaviors, prevention, or wellness. And health literacy is mentioned once in it, and in this whole set of standards, there's only 14 references to literacy. I see there's kind of a problem in that if we don't have this basic communication construct understood by our practitioners and implemented in the organizational structure, how can we possibly expect any types of substantive advances? So my question is, what's going on, I guess?
Rima?
If I could address just part of that, it is not terribly dissimilar for what's going on in medicine, in dentistry, in any of the social service fields. I am very eager to move to action, and I guess I've been informed more by Roger's work over the years. I keep returning to it, diffusion of innovation, and I have to remember that the diffusion process is very slow. And so we do have to be more patient than we are. It's not public health alone. You see the exact same thing in medicine, where we think that the message has gotten out, but it hasn't. We have to repeat it. We have to make friends. We have to be available. We have to give our services and offer briefings over and over again. We have to offer, maybe at the very beginning, out of the goodness of our heart, we have to offer training programs at low or no cost. We have to go out there and continue to employ others to hear us by speaking better, by doing more.
I think that we need to do work to help set a standard of evaluating the information that's put out as information for, not just for the general public, but especially for specific population groups, and to have a higher standard that if it hasn't been evaluated, it's simply not good enough, and unfortunately it very often isn't good enough. I saw a poster a grad student had done recently looking at the reports sent to women following having a mammogram. And she was trying to see, grade them on different levels of whether they communicated the information such that you would know what to do. And only about 5% came anywhere close to being intelligible in saying, you are past, this is fine, don't come back for 2 years, or 1 year, or there's something wrong, this is what you do, this is what it means. And that was an area where nobody thought there would be any problem. And that's the tip of the iceberg. We really have to set standards, and unfortunately, I think one of the ways that would be most effective in making a difference is having some publicly available services, some centralized areas where it is free for departments to show and validate that they've met some standards. Unfortunately, A lot of people think it's as easy as hitting a function on a Word program, or that they know how to talk to somebody who has less education, so they could run it by their child or something. It's obviously much more complicated than that, sharing information about complex issues with people and validating that it reaches them effectively. So we need to explain the whole problem and concept of health literacy to the people who are responsible for serving many populations.
And I'll just briefly build on Rima. I agree, Rogers is a perfectly fine model, but recall that also tells that it requires information leaders and champions. That's what kicks off the diffusion process, and those can be created. And in fact, I think that if you look at the initial 10 years ago, the prescription to end confusion created a lot of information leaders and champions. I think that can be done again with a broader audience. We can proactively kick off the diffusion process.
Thank you, George. Dean Schillinger from University of California, San Francisco and San Francisco General Hospital, part of the San Francisco Department of Public Health. We've been talking a lot about departments of public health, and Andrew, you surveyed them, and I've tried to survey them as well. I know how hard that can be. One of the major crises in this country is that public health departments, be they at the state level, be they at the federal level, or the local level, are severely in distress. And part of what was discussed today is what can health departments do. But I believe there's a fundamental problem related to health literacy, which is people's lack of understanding and belief in the concept of public health, understanding what is health promotion, why we as citizens need to support institutions that promote public health, and reframe how we think about those health departments and those activities that those health departments do. When I talk to my patients about what is a health department, they say, oh, that's where you get your gonorrhea and chlamydia checked out, right? I mean, that's what people think about local health departments, sexually transmitted diseases. So we have a fundamental problem that is a health literacy problem in translating the meaning and value of public health to the general public. What do you guys think about that problem?
I'll reverse order this time. Dean, I completely. Oh, sorry, I thought this one was doing it. Dean, I completely agree with all of that. But just like health literacy, I think we also need to remember it's a two-sided problem. That part of that problem lies within public health. And I think the adoption of health literacy within public health is the way to change that fundamental lack of understanding of the role and mission of public health. I think that, the essential services, the attributes, some of those might very well change. There might be a lot of things that public health departments do now that they rethink due to lack of effectiveness, and say we can put our limited resources into health literacy and have a much bigger effect and change the perception of what it is that we do among the general public. And that can become a self-perpetuating growth cycle, in my view.
I also think that it has to do with the dissemination of findings. So public health departments and the CDC do an excellent job in tracking, monitoring, and gathering data. What they don't do a very good job in is translating the findings to the public. So bringing those findings to the public in understandable ways really would highlight the efforts of public health, ironically. It would highlight not only the identification of problems, but what public health did to address it. And that's the missing element. So we're not doing enough of bringing information back to the community. And as a matter of fact, there are ways of bringing information back to the community that engage the community. So just as we have in traditional papers or dissertations, we have a data methods, of course, section, but we have findings section. And after the findings section, we have the analysis, where we do more sophisticated analyses of the raw data. Well, if we bring the findings back to the communities and we ask community involvement in what does this mean to you? What are the possible interpretations? Did we leave out any information? Does this resonate with you? And what are the possible solutions that occur to you? That level of engagement, all based on the findings that are there for us, would really engage populations and communities in a very different way. And so I think it really is a little bit of a shift in the emphasis from collection to dissemination of data, and to dialogue. And it's not all that hard to make that shift. And I think that we can be there as aids in helping that translation process take place, so that we're not turning back data with statistical analyses. We're turning back data in clearly understood findings.
I think that we can go another direction to make a difference. I think that we ought to be teaching how public health works as part of health education in schools. I think my kids should be learning at school that there's things about individual health and there are things about population health, and it shouldn't be taught at home. It's not a religion, it's a science. And I think that, but if they don't learn there, most kids don't go to a home where they're going to have an understanding of how one part comes across from one side and one from the other. We're not going to explain to people in a doctor's office how vaccines work and why, and how you'd get information, how you would be health literate as an individual. We have left a lot of this blowing in the wind, and it's undermining public health, and it's even undermining us in some populations that are educated enough to be skeptical, but not necessarily educated enough to sort through the literature in a way that matches their own concerns about risks. So I think we need to expand the fronts considerably.
Winston?
Thank you. Winston Wong, a member of the Roundtable, and thank you for your very excellent presentations to start off our day. And I thought Dr. Pleasant's map of the, I would guess, probably at least 50% or more than 50% of public health departments statewide don't have anything related to health literacy. It suggests that this is not on the agenda with regards to how health departments see part of their ability to survive in the 21st century is linked towards their capacity and competencies in terms of directing health literacy. But along that line, I wanted to offer an opportunity for you to reflect on perhaps the latest headline in the last week, that it's not, it kind of bridges both public health and clinical medicine. The whole controversy around using the risk calculators to put large proportions of the American public on statins to lower heart disease. How would you think a public health department could be more effective in making that message clearer to the public as an example?
You did it, Winston.
That's an excellent question, Winston. Now, do we have a response?
One of the papers that you have in the workbook is an old paper that I had published on looking at the postcard that came out from the Postmaster General about the anthrax issue. I think what's underlying that is the lack of rigor behind our public communications in general, not just in health. We don't seem to take scholarship seriously in that our formative research is sorely lacking. We are not somehow or another truly working with members of the intended audience to craft our tools, to see that they're usable and understandable, to test out our message, to see that the appropriate language is being used and that they're comprehensible and action-oriented. So going back to the old rigor that has been well documented in health education for a century, of testing out and working with members of the intended audience will get us there. I'm very confident in that, because in working with people members of community, people who don't have the same degrees that I have gained the most insights, because these are the people who are going to use it and they can tell me whether it's usable. These are the people who need to put it into action and they can tell me if it makes sense or if it's in the right or wrong language. So I think it all lies in the rigor of how we develop our tools, our materials, and our messages.
This actually hits an area that's my primary area of work right now, which is looking at how do we address gender, racial, ethnic, and socioeconomic disparities in ambulatory care for cardiovascular disease and diabetes. And so there's been an assumption when I go and talk on this, especially in the past week or so, that changing to recommending that we just, put statins in the water, it's close to it, that high cholesterol is the result of a lack of statins in your diet, it's a problem. But the assumption of many in the audience is if we change the guidelines, the problem will now go away, with no understanding that unless we educated people why they would be on statins, why we are shifting our concerns about cardiovascular disease. The idea that we've got a growing understanding that as population, as longevity increases, you will eventually have heart disease, and this is a different way to come at risk, involves all the pieces we've been talking about here of how do you communicate to people about it, and if you don't, how is this going to greatly further increase racial, ethnic disparities, gender disparities. More men go on these treatments and benefit from them than women, and nobody's looked at it. We have had no priority of assessing this. It's a perfectly horrible, perfect example of the kinds of problems, and that the healthcare of the general population does not shift because a guideline shifted. It's got a long way to go down, and it goes down through us. It's our job to figure out how to make it happen and how to educate people and how to talk to people about risk. Unfortunately, the only place I see a lot of that work go on with a lot of thought ongoingly grappling around it is how to get consent to participate in a study. And that's the one place that people spend a lot of time thinking about it and admitting, at least on the research side, that we're really bad at it. The one explanation being asking a patient at the end of the consent process to explain it back to me. And she said, well, apparently if you pick my one arm, I get surgery. And if you pick my other arm of the study, I get something else. But I don't know why you're using arms. And somebody completely not understanding that what they could give the right answers. But as soon as you said, so what does it mean for you? You find out you hadn't communicated at all with individuals.
So I'll just try to put a quick dot on that. Thanks for the question, Winston. I completely concur with Rima. Formative research, today I'm sitting here in a suit and tie. In 2 days, I'll be on the south side of Chicago doing formative research in a school with a very low-income population, and their expertise in survival is phenomenal. So for a very small amount of money, just think of this, the inclusion of a health literacy scholar and some local experts to look not only at the example that you raised, but let's talk about healthcare.gov for a minute. How much money could that simple step have saved in wasted effort and time across the nation? The cost we would bring to that development process pales in comparison to the potential savings and increase in health that we could have possibly created.
Yeah, I guess I'd make a comment as well. I worry that the issue around the risk calculators indicates a insufficient, vigorous public health participation in the debate about these guidelines. That's what I worry about, quite frankly. Next comment.
So I really appreciated Linda Neuhauser from Health Research for Action Center at the School of Public Health at UC Berkeley. I really appreciated all of the presentations and comments of the panel and colleagues in the audience. And I have a couple of comments. One, I wanted to underscore what Rima said about translational research. For many years, I've defined what I do as translating research into practice, but I've come to realize in recent years that it doesn't work, that you can't actually translate research into practice and assume that it will be successful. What does work is to engage the end users and stakeholders in the design, implementation, and interpretation of the research from the very beginning. Consider if that had been done with healthcare.gov, with risk factor calculations, as Winston was talking about. So in my view, that's the only thing that works. And so it's a tremendous transformation of how research has traditionally been done. It is now called, let's say, action research. But if we really want to have an impact on public health, we have to do action research. And part of that action research, as you were mentioning, Chloe, the problem with consent, is to have participatory design of consent forms so that before anybody consents anyone, we already know what's going to work or not work. And I've been doing a lot of work in that area. A comment to you, Andrew. I want to commiserate with you. One of the exercises I did before coming here was to try to talk to the people at the State Public Health Department in California and find out, first of all, in the area of nutrition, was anybody assigned there that had an interest in health literacy? I got bumped from one person to another. The senior people who do communication and all of that, everyone said, oh, we don't know. But the other thing I wanted to comment was that even though there's no person there in most states that seems to be identified as the health literacy champion or knowledge person, there's a lot going on in probably all states, but it's going to be very hard to find that. And so I will be talking about some of the things going on in California that I doubt you would be able to dig out with this very frustrating situation.
Yep, it's not that frustrating, actually. I'm not surprised. But I think you're right, but it's hidden, and that's the problem. It's a hidden epidemic. And doing what they're doing is continuing to hide the issue.
Yeah, I think one of the points you're making that I think is particularly important is the skill or the capability or characteristic of public health to be expert and skilled in engagement as the first step, not only for research, but for public health.
Yes.
And which I think you highlighted, Andrew, in your analysis. And I think you also,
she may have been
Rima,
ahead of me.
highlighted as well. Go ahead.
I think she was ahead of me.
Oh, I didn't see
Sorry.
her in the bright light over here. Thank you for helping me.
Thank
Go
you.
ahead.
My name is Champagne Fanchan. I'm from Rancho Los Amigos National Rehabilitation Center, which is one of the 4 public hospitals in the county of Los Angeles. And I wanted to represent the vernacular view of the public health and health literacy. And I see a lot of people making comment are from the members of the IOM Roundtable team or committee. And I wanted to share with you the positive lights. Recently, I attended a webinar, which is hosted by the AARP, collaborating with the American Occupational Therapy Association on the notion of we need to talk. It's about older driver and how we can educate adult children to communicate with their parents who are older driver at risk for safety. And I was very surprised and very happy to find out the brochure they have developed are totally focusing on really good concept of health literacy and engaging readers and potential audiences. And this is one evidence that I really think that health literacy has come a long way, and we have a lot of blessings that we can collect. The second example I want to share is the fact that we at the County of Los Angeles, our Patient Safety Committee, in 2008, we have talks about health literacy and how its relationship to medication safety. And health literacy is the term, at least at the managerial level, we really try to do something about it. And the second notion I want to share has to do with action-based information. I mean, America, to me, it's a free country, so we really say, yes, we will lead you to the water, but we're not going to force you to drink. So therefore, we're not going to tell you what to do. And that really is a problem, because we don't structure our information in action-based information. And the general public would not remember information if they're not going to do anything about it. Because a lot of time patients will say, yeah, just tell me what I need to do. So we have an ample opportunity ahead of us. For example, like NCQA's National Patient PCMH standard, Patient-Centered Medical Home standard. One of the elements in self-care, every one of the the factors are talking about how healthcare providers need to present resources, information to patients. and also document how their response, do they understand what they wanted to do. So in my opinion, if we can look at where the money goes, why would people work on consent? Because if they don't do a good consent, legal issue, and then money. And I can tell you many, many examples. If we can somehow link action-based information, which is a great way to do knowledge translation, to where the money goes and the standard, and focusing on the future of healthcare, which is train, educate our public, how to be a good collaborator to navigate their own healthcare. And I think that may be a place where we have a lot of audience, and that we're not going to be able to sit here and say that public health doesn't work with us, because I do agree public health is under a lot of stress financially and manpower-wise. Thank you.
Thank you. Response?
Well, I would just say that I think it's not only where the money goes, but that for research, we have a mechanism of a review process that's mandatory. It's far from perfect, but the fact that you have to get review and have to get sign off on consent forms by somebody, and that we answer to people makes a difference, and we don't have that in place at this time to say it's patient education information sufficient.
I'm thinking about different consent. I'm thinking about
Just consent to, yes.
Yeah. Thank you. We got this question?
Yes, thank you. My comment is to Andrew also, sort of a follow-up to Linda's. My name is Alice Horowitz, School of Public Health, University of Maryland. On your map, Maryland was very, very pale. But I have to tell you that there's a lot of activity going on there, and including from the State Health Department. And I think you're correct that it's just hidden. For example, CDC even gave the Department of Health in my state a large grant to do an oral health literacy campaign. And I'm really surprised because oral health is, hot item in my state, that somebody didn't recognize that health literacy is on the agenda. Even, we have a state oral health plan. One of the 3 focus areas, one of them is health literacy. So I think that maybe things are better than what they appear on your study. And I'm optimistic.
I think that may well be the case. Yeah. I think the point, though, that if I can just jump in here, that I take from this is the fact that in communication, listening and response is the first step. And we have at least more than half of the health departments that don't respond through their public portal. Right. And yes, the stuff is hidden, but it's hidden because of a fault in communication. And the first part is listening and responding. So I'm sorry to jump in there, but go ahead and make it.
No, ditto. I agree with both of you. I'm sure that many of the states in white have somebody in their organization who's thinking about health literacy or has thought about it. But if their activity hasn't gotten to the point of a public presence that's actually notable, and so that you can walk in the door of the public health department and say, boy, I'd like to start a health literacy campaign, and they can say, you need to talk to, because those states in white clearly can't do that.
Go ahead, Rima.
I think that we have to be better informed about new, novel, innovative communication strategies. I think we're a little bit behind the ball when we think that a query in writing will produce the answer that we need, or that materials given to people will produce the action. There's something missing that we haven't yet caught on to. Sometimes it's timing. Sometimes it's the weight of the query at a bad moment in time or financially. So I think we need better strategists along with us who are truly communication experts in all the new realms of communication. I mean, a sad story that I experienced is that I developed, pilot tested with rigor, a how-to guide for state departments and local departments of public health to put on health literacy forums. They were mailed to every single state department of public health, every regional department of public health, and every major city in the United States Department of Public Health. This was in 2004. getting something in the mail didn't do it. It didn't do it. And I hadn't sufficiently thought about the strategy of disseminating that material. I didn't get the help that I needed. The material is in hard copy. It's there. It's somewhere. But this underlying strategy, I think, is something that I needed help with back in 2004, is something that we continue to need help with, especially when some of us are troglodytes like me, with the newest, I mean, Facebook isn't used by any young person anymore. It tends to be acronyms that I no longer know what it means. People tweet and Twitter and do other things that I don't know about. So I think we need help.
And I've got a couple questions, too, before we wrap up this section. For Chloe, you had some really nice examples of mapping with areas and made the nice point about the fact that people are very much affected by whether they're in a high literacy versus a low literacy area. I thought that was a very elegant point. Do we have an example using those maps where we have an intervention that's changed the level of literacy in one of those local areas that's documented that we can learn from?
The work that we've been using, it hasn't been to intervene and change health literacy, but to inform how people are communicated with about their health risks, or how patients are triaged to get additional information from the pharmacist about how to take their medication, so that they know that this one is a shampoo. You don't take it orally, even though the pharmacist just gave it to you, because there are horrible cases of kids being given lice shampoo as an oral medication. They will end up with seizures. So being able to have something there that helps a health plan understand that they can't, not only can they not ignore health literacy, but that by recognizing that health literacy problems result in people not being able to make it to their appointments because they can't read the information and understand exactly when they were supposed to be there. And they certainly can be a huge barrier to coming in properly prepped for an expensive and important test that they need to have. And so if they understand they're already experience a cost and consequence of people unable to show up or people unable to come in prepared, then you can help them make a decision to redirect some resources to having a follow-up phone call, going over orally with someone what in fact it means to be able to come in prepared, what it would look like to come in, instead of handing somebody a sheet. Because I would argue the consent for procedures example before isn't about health literacy at all. It isn't often, unfortunately, isn't about communicating with people correctly. It's about either cover your ass or meet the legal obligations. Sign this so that your kid can go get this surgery right now. Sign this so that you can go in and get this, whatever it is, taken care of right now. And it's not about assuring that the communication happened. I would love to see the literacy testing used to go in and intervene, but we've been on the healthcare provision end.
So we still have to get to the point where we intervene in a geography to change the level of literacy and see the impact.
I think so.
But Rima?
Just a note, in the 1990s, Steve Reeder, R-E-D-E-R, from Portland State, did a piece of work for the Department of Education. It's a rather thick book. And based on the 1992 statistics of adult literacy in the United States, he was able to use computer modeling to look at exactly where there are pockets of low literacy. And so there's an analysis for every single state, and there's an analysis for regions within every single state, and there's an analysis for literacy skills within every single municipality of every single state. So that data existed in the 1990s. Now, his hopes as an adult educator and linguist was that this information, where complete pictures of every state exists, would inform policy around funding for adult education, so that there could be clear interventions. Needless to say, adult education is even less developed and less funded than is public health. So the attempt, and I think to work on that in conjunction with partners in the adult education and education field, would perhaps further our efforts in health education. So that potential exists, that work is there.
So, Andrew, your survey revealed the fact that there's significant differences, point of view in terms of the definition of health literacy among the various respondents that you did have respond to your survey. Is it time for a different definition of health literacy?
I did not pay him to ask me that question. Those of you who know, clearly I think,
Enhanced
yes,
or?
I've thought yes for quite a long time. And if you look at the measurement issues that we have in health literacy, the absolute disconnect between the existing screeners and our definitions right there, from just an academic point of view, we have a need. But in terms of actually producing policies and programs that work and can make a shift at the county and governmental level, we absolutely need a definition that can inform the creation of a valid and reliable measurement tool to demonstrate those changes. That's the only way this field is going to grow and survive, in my personal view.
Okay. Also, you also talked about the fact that there's a big difference of opinion in the survey about this notion of a two-sided sort of feel about health literacy. In other words, the individual skills side versus what I'll call the simplification of the interface to the two individuals of public health or of some intervention. And it seems to me that we have just a tremendous current example of complexity of an interface in terms of the unfortunate problems that have occurred with respect to the ACA and signing people up, which basically has turned the whole country into basically health illiterate because they can't navigate the interface, or most of them can. And only the most persistent and the most best educated are going to get through at this point until those issues are solved. So what about, I'm thinking about the attributes of a health literate organization. How much, are we giving enough emphasis in public health and in policy to simplified design and design of interfaces, design not only of communication and communication terms, but design in the sense of web portals, of interventions and so forth?
Resounding no.
No. No, I keep hearing of public health departments creating coalitions within their state, county, or territory and receiving really significantly large amounts of funding to address public health. And then 2 years later, I see that nothing's changed. And,
Rima?
We do have tools. ARC developed a tool for assessing websites from the perspective of health literacy. Just as one example, people are not using the tools that are available. People are not applying the knowledge that is currently available. So the answer is no. And so again, the issue is convincing, discussing, promoting. So we have the availability right there. We have the knowledge to a large extent right there. We have to develop it further in some instances. But it's the communication and it's the persuasion that has not been successful to date. And we don't quite know why.
You need to move the microphone.
I will, while you're going to the mic, I would just.
I'll wait for you to get there, Dean.
And while Dean's
Because I want to
going,
hear
I'll
what
just,
you have to say.
reinforce, I think one of the ways
Yeah.
to do that is, in fact, to revisit the initial, just to repeat the point, right? That had a tremendous impact on clinical and medical and lesser to public health, the original volume. And if another volume is revised, updated, created from scratch, we can have the same impact with a larger audience.
We
think we
should
need a-
also, I think, perhaps consider as members of the roundtable, whether our attributes that we've seen, whether that emphasizes that as much as it needs to be given this most recent example. Dean?
Well, I was just going to say that in response to Rima's comments, I had both the misfortune and good fortune of doing my medical training during the peak of the AIDS epidemic, and I was able to witness how a health department could partner with an empowered citizenry. The gay community was extremely active in driving the research agenda and in shaping the ways in which the health department created messages the ways in which the health department engaged with the affected communities, such that within a decade, we were on top of it. And it was an incredible example of how an affected population and an open-minded health department can create dialogue. It was not without tension and conflict, for those of you who've read about it, but it led to a really miraculous outcome in under a generation. So there are models. I'm sure there are others in tuberculosis and perinatal outcomes in the developing world where these things have gone well, and I think we should try to learn from them.
But I would add, in that example, you're talking about the success that was attained by a highly educated, highly literate population able to use the machine, and that's what we'd want to be available to other groups. But they had status and prestige and insurance and so on.
However, the strategists in the HIV/AIDS movement learned from the civil rights movement.
Oh, yes.
Directly, and attribute that. The women who organized around breast cancer went out to San Francisco to learn from the HIV/AIDS activists. So this knowledge is not just in a highly educated community. You see it. You see the lessons learned in environmental justice movements. You see it in the civil rights movement. Those are the lessons of engagement that we need to learn from.
So
Thank
we're
you
about,
for
we're
pointing
about
that out.
eight minutes behind our schedule, but
Just,
go ahead.
just
you
to
make a
say,
comment.
that's absolutely right, but it also can happen from within public health. We don't need to say, oh, the public isn't activated enough, which is true. But I mean, we know at Canyon Ranch Institute of one of our partners in the South Bronx who's proactively working with the business community to change the way, for example, that sodas are displayed and sold across the community. So that, low fat, low sugar has the same shelf space as high fat, high sugar. Well, sorry, not high fat, but high sugar. Right, that can happen from within public health and from within clinical. We don't have to wait for an empowered community.
So we're behind, but I'm going to incline to take these comments if they're brief and to the point. Go ahead.
I'll be brief. Catherine Atchison, UCLA.
Come close to the microphone, please.
Catherine Atchison, UCLA. I think one of the things that we neglect is to adequately involve the youth in the development of tools. There's a group, for example, in engineering where students just do, it's like a codathon or hackathon thing, developing tools for people who are disabled. And those type, you saw it with the ACA, where the Sherpas, the Sherpa group up in Northern California developed in 3 days something that could improve drastically how the information was presented to people. And I think that our age group is not the group that's going to develop the appropriate tools for people to really respond to, and we need to have the right people working on it.
Thank you for that comment. Let's take the next one real quickly here before we go to the break.
My name is Marie Fongwa from Azusa Pacific University School of Nursing. And I'm wondering whether it's time for us to train or educate a group of people who will effectively do this kind of translational research. We want to call it action research or something like that, because the information is there. Maybe those of us who are here now and working on it are tired, and probably we need to tool it in such a way that it captures a new group of people who will be trained specifically for translating the research results into practice. Recently, or maybe in the last decade, schools of nursing started training doctor of nursing practice people. In public health, we have doctor of public health and so on. Maybe we need to train or educate a group of people who will actually translate these results into practice.
Thank you so much for that comment. I'm going to conclude this session and by making the observation that the Institute of Medicine in a report, series of reports for the public's health, the third of those series that talked about investing, made the point that public health is underfunded, recommended that another $12 billion be spent on public health incrementally, recommended a mechanism for raising that revenue, and recommended a minimum set of essential services that every individual in the country ought to have access to through public health agencies. And so one of the things that we might think about as we go through the remainder of the day is what sort of role that health literacy might play in that minimum set of essential public health services. And then I wouldn't want us to end this session by thinking that we've beat up on public health and that it's in bad shape, but it's in bad shape because it's underfunded and it needs a lot of help. And so I hope we're drawing attention and giving tangible rationale to the reason that additional investment is called for. So with that, it's 12 minutes past the hour by that big clock up there. I think we should take our break and come back at about 25 past the hour, and we'll make up the time some way. Thank you so much to this panel. Please join me in thanking them.